Having looked into airway topicalization and nerves block in our previous sessions, we will now dive into how we provide sedation for awake fiberoptic intubation. So, let's start with a simple question: why do we even need sedation, when topicalization or nerve blocks already do a great job of numbing the airway? Well, the short answer is, sedation makes the whole process a lot more tolerable for the patient. Being awake while someone is passing a scope into your throat is an anxiety-provoking experience. Sedation helps take the edge off that fear and anxiety, making the patient more cooperative. Now, one thing we always need to keep in mind is the depth of sedation. If we go too deep, we can tip the patient into apnea, and that's dangerous. Remember, we're doing awake fiberoptic intubation because the airway is difficult. If the patient stops breathing, we may not be able to ventilate or oxygenate them at all. By keeping the patient spontaneously breathing, we give ourselves a safety margin. It means that if the fiberoptic attempt doesn't work, we can pause, step back, and consider another option, like an awake tracheostomy, without losing control of the situation. When we talk about sedation, it's important to remember that sedation exists on a continuum. A patient can drift from mild sedation into moderate, from moderate into deep, and if we're not careful, they can slip right into general anesthesia. We define sedation level using 4 parameters: responsiveness, airway control, breathing, and cardiovascular function. If we look at this table, we can appreciate that breathing and airway is maintained only during minimal and moderate sedation. Beyond that, in deep and general anesthesia we more likely need intervention on our part to maintain airway and support ventilation. So for awake fiber optic intubation, we aim to target the sedation at the first 2 levels where the patient is responsive to verbal or tactile stimulation. Regarding the drugs used for sedation, they generally fall into 2 categories: those that are primarily anxiolytic, and those that are mainly analgesic. Some of the newer agents actually have both properties, which makes them very useful. The common drug classes include benzodiazepines like Midazolam, opioids such as Fentanyl and Remifentanil, alpha-2 agonists like Dexmedetomidine, and of course Ketamine and Propofol. Drugs that provide both anxiolysis and analgesia are usually preferred for awake fiberoptic intubation. In practice, we often combine agents to achieve this. For instance, a small IV dose of Midazolam or a low-dose Propofol can help reduce anxiety and give some amnesia, while an opioid or a Dexmedetomidine infusion provides analgesia and light sedation. The most important point is to titrate carefully, aiming for a level where the patient still responds to commands or gentle stimulation. Dexmedetomidine is one of the preferred choices for awake fiberoptic intubation. It works as an alpha-2 agonist, which means it provides sedation, reduces anxiety, and even adds some analgesia, but the real advantage is that it doesn't depress breathing. Patients remain cooperative and can still follow simple commands, which makes it ideal for this setting. In terms of dosing, we usually give a loading dose of 0.5 to 1 microgram per kilogram over 5 to 10 minutes, followed by a maintenance infusion of 0.2 to 0.7 micrograms per kilogram per hour, titrated carefully to effect. Another benefit is that it helps keep heart rate and blood pressure more stable, and it reduces secretions, which makes the whole process smoother. That said, we do need to be careful. Bradycardia and hypotension can occur, particularly if the loading dose is given too quickly. Remifentanil is another very useful drug for awake fiberoptic intubation. It's an ultra-short-acting opioid, which means it comes on very quickly and also wears off just as fast. The reason we like remifentanil is that it gives strong analgesia and, at the same time, suppresses coughing. This makes it much easier to pass the scope smoothly through the airway. We can give it in 2 main ways. One is as a target-controlled infusion, usually set at about 1 to 4 nanograms per milliliter. The other is as a continuous infusion, typically around 0.05 to 0.1 micrograms per kilogram per minute. But there is a risk. If the drug is pushed too fast, patients can become apneic, and in some cases even develop chest wall rigidity. So the key is to start low, titrate slowly, which is easy because it doesn't accumulate in the body. Another limitation is that remifentanil doesn't provide much in the way of amnesia. Patients may still recall the procedure, which is why we often pair it with a small dose of a benzodiazepine for comfort. Fentanyl is another opioid that's widely used for awake fiberoptic intubation. Its onset is fairly quick, usually within 2 to 3 minutes, and the effects last around 30 to 60 minutes. This makes it very useful for providing pain relief and suppressing coughing while we pass the scope. In practice, we usually give fentanyl as small intravenous boluses, around 25 to 50 micrograms, titrated carefully to effect. One limitation compared to remifentanil is that fentanyl is longer acting, so once the dose is in, we can't adjust it as precisely. That said, fentanyl is widely available, and familiar to all of us. Like remifentanil, there is a risk of apnea or even chest wall rigidity if given too quickly. Another point is that fentanyl doesn't provide much amnesia, so patients may still remember the procedure. For that reason, we often pair it with a small dose of midazolam to improve patient comfort. As we've already discussed, benzodiazepines like midazolam are primarily used for anxiolysis and amnesia, helping to prevent the patient from remembering the procedure. Midazolam specifically is a short-acting benzodiazepine. In adults, an initial dose of about half to 2 mg intravenously, given slowly and titrated to effect. Unlike opioids or dexmedetomidine, midazolam doesn't provide any pain relief, so it's typically combined with an opioid such as fentanyl or remifentanil. We also need to be careful with dosing, because overdosing can lead to respiratory depression. Other benzodiazepines, like low-dose diazepam, are used less often due to their longer duration of action. Just like dexmedetomidine, ketamine provides both sedation and analgesia. It creates a dissociative state, and the major advantage is that patients usually maintain their airway reflexes and continue to breathe spontaneously. For awake fiberoptic intubation, we generally give it as a low-dose intravenous bolus, about 0.2 to 0.5 mg per kilogram, and if needed, small boluses can be repeated. One additional benefit is that ketamine causes bronchodilation, which is particularly useful in patients with reactive airway disease. On the downside, it increases secretions, so we usually give it together with glycopyrrolate. It can also cause emergence phenomena, but this is much less of a problem if it is combined with a benzodiazepine. Propofol is another agent that sometimes comes up in the discussion of awake fiberoptic intubation, but its role is actually quite limited. The main reason is that propofol, while being an excellent sedative and hypnotic, does not preserve airway reflexes or spontaneous breathing. In fact, it often suppresses both very quickly, which makes it less ideal for a truly awake intubation. If propofol is used, it should only be in very carefully titrated, small doses, usually as a slow infusion, around 25 to 50 micrograms per kilogram per minute, rather than a bolus. Some anesthesiologists keep it as a backup, giving tiny boluses of 10 to 20 milligrams if the patient becomes too anxious or uncomfortable. So, to wrap things up, when we're choosing sedatives for awake fiberoptic intubation, the main point is that a combination of anxiolysis and analgesia works best. Drugs like propofol, or other 4 hypnotics, are usually avoided on their own because even small doses can abolish airway reflexes and potentially cause apnea. One important takeaway from recent evidence is that there isn't a single best sedation regimen. What really matters is picking an approach that you can titrate safely. Even more important than the choice of drug are the basics like good technique and maintaining oxygenation. At the end of the day, it comes down to using agents you're familiar with and applying them carefully. Though not a sedative agent, we must mention glycopyrrolate as a premedication or adjunct during awake fiberoptic intubation. Glycopyrrolate works by blocking muscarinic acetylcholine receptors, so essentially it reduces salivary and airway secretions. One of the big issues during the procedure is excessive secretions, which can fog up the scope and make intubation more difficult. We usually give it intravenously, about 0.2 mg, around 15 to 30 minutes before we start. What's particularly nice about glycopyrrolate, compared to atropine, is that it doesn't cross the blood-brain barrier. So it doesn't cause sedation or central nervous system side effects. It also has the added benefit of reducing bradycardia, which can occur with sedatives like dexmedetomidine or opioids. And in practice, glycopyrrolate is especially useful when we're using ketamine, since ketamine on its own tends to increase secretions.